Good evening, everyone, and thank you so much for joining us for this webinar on Uraemic toxins, which has been very, very kindly sponsored by Porous One, which means that we have been able to bring it to everyone, to the masses, for free, which is absolutely brilliant. So thank you very much to Porous One for sponsoring this session and talking to us about Uraemic toxins. It's obviously a very important topic and very topical as well in cats. We see a lot of them with kidney disease. I can see that we have a lot of people who've joined us, and I can also see that a lot of those names are quite new to me. So I would imagine quite a few people who maybe haven't attended one of our webinars before. So I just want to take the opportunity to go through a few things with you, if that's okay, just to help you get the most out of this session as we go along. Now, you'll see there's a little tab called Resources. It'll be either to the right of your screen, or it might be underneath if you're on a mobile device. If you click in there, you will find your CPD certificate to download, as well as some other really useful information which you can download on Uraemic toxins and, of course, Porous One as well. If the certificate isn't showing at the moment and you've been waiting a little while for the webinar to start, you might just need to refresh your page because that's only just recently been added. So if you can't see it, just refresh your page and it will show up there. But don't worry, this session is being recorded, so the whole of this is being recorded. And you'll be able to access the recording as well as the materials. So the CPD certificate and the downloadable materials will be available for you to come back to if you need to. So don't panic and feel that you have to do everything at this moment in time. You will get an email tomorrow, probably around about this time, which will give you the link to that, and then you can come back and watch as many times as you want, and if you want to come back and download things, then you can do that then as well. So just sit back and enjoy this evening, I would say. We will have time for questions at the end of the session. There is a little chat now box, so if you use that to type any questions that you have, please do that at any point during the webinar. If we do end up covering it throughout the webinar, then I'll know, so I won't ask your question anyway. So please just type it along. The earlier you can get your question in, the more likely we are to pick it up and answer it as well. So that can be anything relating to, obviously, Uraemic toxins and CKD, as well as if you have any products questions as well. So please do feel free to chat or just say hello. Lots of people just saying good evening and hello. So it's really nice to see you this kind of a new age where everything is so digital and virtual. We don't actually get to physically meet each other, so it's nice just to say hello as well, isn't it, on there in the chat box. So I'm absolutely delighted to introduce Dr. Jose Motet as our speaker tonight. Now, Jose has a vast experience as a small animal practitioner, many years in practice, and he's also spent many years working in the veterinary pharma industry. So he has a huge experience from kind of both sides, so from kind of on-the-ground experience as well as the technical side as well. So he's going to do the main presentation. At the end, we then have Dr. Niklaus Kolwick, who'll be joining us as well, and then together the three of us will discuss any questions that you have, like I say, about Uraemic toxins and CKD, as well as the product Porous One, which Jose will obviously go through in the session as well now. So please type any questions in the chat box as we go along, and then I'll pick them up and we'll have a chat through those at the end. So that's enough from me, I think, and I'll hand over to Jose.
Hello everybody, thank you for joining in. In this webinar, I will be talking about the latest discoveries in the Uraemic syndrome in dogs and cats and go through some new developments in the treatment of this syndrome. I hope you will enjoy. Now, when we talk about chronic kidney disease in cats, we know that it's a disease that we see often especially in first-line practice. About 4% of cats that are presented on a daily basis to us will have some degree of CKD, and the disease is more prevalent when the cats get older. 30 or 40% of cats over the age of 10 will be affected by CKD. We don't know what the real cause is. We don't know if it's one single cause or different mechanisms. We know that the end result is some form of chronic interstitial nephritis and a lot of fibrosis, but we still have to figure out what the underlying etiologies are. In terms of clinical signs, there's not one single sign that is very specific to the disease. They're all non-specific, like weight loss. We know that that's one of the earliest signs of CKD, but again, it's not specific. Cats are usually presented dehydrated when they are already in advanced stages. They could be presented for polyuria, polydipsia, for a bad breath because of the ammonia smell, but again, no clinical sign is specific for CKD. To diagnose the disease, we take a blood sample, a urine sample. In blood, we will be looking for elevated levels of urea, creatinine, SDMA, and if we can show azotemia in two separate blood samples taken a few weeks apart, we're almost sure that there's CKD present. And in the urine, we will be looking for a low specific gravity. Of course, we have to rule out other causes of pre-renal and post-renal azotemia. But once we have our diagnosis, we can stage these cats. And this is described by the IRIS guidelines quite some years ago. And we stage them from stage 1 to stage 4. Now recently, the staging is based on serum creatinine levels. So from stage 2 on, this means that serum creatinine is going up, meaning going higher than 140 micromole per liter or 1.6 milligram per deciliter. And then when the disease progresses, cats go to stage 3 and stage 4 based on their serum creatinine levels. SDMA has now also been taken into account, and the guidelines have been updated with specific guidelines on SDMA concentrations. There's some substaging for cats that are proteinuric. We know that proteinuria is related to disease severity and progression of disease, and we consider cats to be proteinuric if they have a UPC or urine protein on creatinine level higher than 0.2, borderline. Higher than 0.4, they're really proteinuric. And we look at systolic blood pressure as well. So there's substaging for systolic blood pressure, there's substaging for proteinuria, but the main staging is done based on serum creatinine levels, and now also with the help of SDMA blood levels. For more information, you can look up these IRIS guidelines on their website or on the paper that is mentioned here, and that has been published in the Journal of Feline Medicine. Now, when it comes to treating these cats in first-line practice, what is it that we usually do? Well, we usually treat for hyperphosphatemia. And how do we do that? We add in a renal diet, because we know that these renal diets contain less protein, and less protein means less phosphorus, so the phosphorus uptake will go down when we feed these cats a renal diet. And we can combine the diet with a phosphate binder. When these cats are proteinuric, we usually add in an ACE inhibitor like benazepril or an angiotensin receptor blocker like telmisartan. When these cats are hypertensive, we treat them with amlodipine as a first choice. And when this is not enough, we can add in an ACE inhibitor or again an angiotensin receptor blocker. Especially in more advanced stages of disease, late stage 3, beginning stage 4, these cats are usually anemic, and in countries where these products are available, we can treat them with recombinant human erythropoietin or darbepoietin. But then there's this myriad of clinical signs like vomiting, diarrhea, anorexia, weight loss that are all related to the disease process in cats. And we all treat them symptomatically. Like vomiting, we give something against vomiting like Serenia or any other drug. For anorexia, we can use appetite stimulants like mirtazapine or gabapentin. There's a recent paper in the Journal of Feline Medicine and Surgery showing that gabapentin has some beneficial effects on the appetite of cats. But we consider these clinical signs as being separate entities. We don't really consider them as being part of the Uraemic syndrome. And it's a bit like the elephant in the room. We don't usually talk about it as being the Uraemic syndrome, while they are all related mostly to the presence of Uraemic toxins. And this is what this webinar will be about. We will be talking about this Uraemic syndrome, what it means, and how we can eventually treated. Now, when we talk about uremic syndrome, we have to talk about uremic toxins. And when we talk about uremic toxins, we have to explain what the difference is with uremic retention solutes. Not every solute that is retained in the bloodstream because of a diminished kidney function is a toxin. And this is what is shown in these tables below. In human medicine, uremic retention solutes are categorized based on their physicochemical characteristics. So on the left, you can see these small water-soluble compounds. They are small because their molecular weight is less than 500 Dalton. And a few examples are urea, creatinine, SDMA. What we know from these molecules is that they're not really toxic. They are retained because of the kidney that is not functioning well, but they're not toxic. Toxicity goes up when we go from one class to another to the middle class is more toxic than the class on the left, and the class on the right is even more toxic. In this middle class, we will find these larger solutes that are retained, like cystatin C, and there have been some studies on the influence of or the role of cystatin C in kidney disease, hyaluronic acid, and there are others, interleukin-6, tumor necrosis factor alpha. They're all retained in the blood, but they're not that toxic. The toxicity is especially in this category. And actually, in human medicine, five molecules have been identified as being extremely toxic. And one of the most studied of them is indoxyl sulfate, which you can see here at the top of the list. So we will look at this indoxyl sulfate in human medicine, in veterinary medicine, and what do we know about this molecule. Actually, indoxyl sulfate is formed in the liver, but let's go one step back. Let's look in the diet. We have these proteins in the diet, and of course they are degraded to amino acids. And one of these amino acids is tryptophan. Tryptophan actually is transformed to indole by bacteria in the gut. Mainly bacteria, mainly E. coli. Coliforms are responsible for the transformation of tryptophan to indole. Indole is absorbed, comes into the bloodstream, goes to the liver, and will be sulfated. It will be transformed to indoxyl sulfate, and this is the toxin. So indoxyl sulfate needs to be eliminated, and the kidney is responsible for doing that. So indoxyl sulfate, once it gets in the bloodstream, goes to the kidney, and the kidney will secrete it. It's an active process. It will secrete it in the primary urine. Actually, it's the proximal tubular cells that will take up indoxyl sulfate and will secrete it in the primary urine. Now you can appreciate if the kidney function is not okay, if the kidney is not functioning well, a lot of this indoxyl sulfate will remain in the systemic circulation, will accumulate, and will have many deleterious effects on many organs. And this is shown in a very nice review paper that has been published recently in 2018. And this picture is also coming from this paper, where all of the effects of uremic toxins on different organs is explained. All of these studies, the many studies have been done on the effect of uremic toxins on different organs, and this is a review paper showing these effects. So what we can see here is that the relation is not unidirectional. So meaning uremic toxins are produced, or their precursors are produced in the gut. They arrive in the systemic circulation, kidney is not functioning well, so it builds up, accumulates, and they go back to the gut. And because of this, what happens in the gut is that the microbiome will change. And ultimately, this will lead to transposition of these, translocation of these uremic toxins back into the systemic circulation. So creating actually a vicious circle. But we know from studies that it's not only or uremic toxins not only have an effect on the gut, they also have an effect on the heart or the cardiovascular system, where we know that there's a lot of calcification going on of arteries. There's a lot of arteriosclerosis going on. We know on fat cells, there's an effect on fat cells. It will induce insulin resistance and ultimately lead to type 2 diabetes in men. We know there's a function on the kidney. So not only is it retained in the bloodstream because of the kidney that is not functioning well, but it has a toxic effect on the kidney itself. It causes fibrosis, it causes podocyte dysfunction, and ultimately will lead to progression of CKD. Indoxyl sulfate, uremic toxins, have an effect on red blood cells. They decrease the production of erythropoietin, and they cause the death of these red blood cells, so leading to anemia. They have an effect on granulocytes, on white blood cells, and they have an effect on bone, or they decrease bone turnover. They have an effect on calcium and phosphor metabolism. Now let's look in a little bit more detail what is happening in the gut. I told you that the microbiome is changing, and this is actually shown in this study. It's a very complex slide, and I won't go through all of the details, but most important, what we need to know for our talk here is that what I already said, the interaction is not unidirectional. So the gut is producing these precursors of indoxyl sulfate, of uremic toxins, and then they get into the systemic circulation. But once they are transformed to toxins and they are accumulating, they come back to the gut. They are secreted back into the gut, where they cause a change in the microbiome. So we know that numbers of lactobacilli, prevotella, these numbers are going down, and these bacteria are replaced by enterobacteriaceae and enterococci. And it's exactly these bacteria that produce enzymes that will produce more indole and paracresol and all of the other precursors of uremic toxins. So actually, the change in the microbiome will lead to production of more precursors of uremic toxins that will ultimately break down the tight junctions between the enterocytes and will make sure that there's a translocation of uremic toxins back into the systemic circulation. So retention of uremic toxins by a diminished kidney function will lead to secretion of uremic toxins in the gut, where more of these uremic toxins are produced and going back and leading to more and more accumulation of uremic toxins in the bloodstream and in different organs. So it's more than just unidirectional. There's a high influence on the microbiome, at least in people. So what do we know about this change in microbiome in CKD in cats or in dogs? Well, there's this one paper, very recent and nice study, where they looked at the influence of indoxyl sulfate on the fecal microbiome in cats with CKD. So they had 30 cats with stable CKD. They had 11 healthy cats to compare with. And they looked at indoxyl sulfate levels, paracresyl sulfate levels in these cats. And they showed that indoxyl sulfate is related to CKD. So the more severe the CKD, the higher the concentration of indoxyl sulfate in the bloodstream will be. And they showed in this study, and we will come back to that a little bit later, they already showed here that cats that are in stage 2 CKD have higher levels of indoxyl sulfate compared to healthy cats. So early stages have higher levels of indoxyl sulfate. So it's not a process that happens during end stage 3 or beginning stage 4. No, it's already starting when the disease starts to be shown, starts to be eminent. Paracresyl sulfate was not significantly different between CKD cats and healthy cats, so we can forget more or less based on this study about paracresyl sulfate. Again, indoxyl sulfate is probably also in veterinary medicine most important uremic toxin. But when we looked at, or when this group looked at the influence of indoxyl sulfate on the fecal microbiome, they showed similar results as what we said earlier. So there was a decreased number of normal bacteria, and these bacteria were replaced by enterococci and other bacteria producing enzymes to produce more of these uremic toxins. So the fecal microbiome changes as well in cats with CKD as it does in humans. with CKD. And one of their conclusions in this study was that indoxyl sulfate first, it's significantly elevated in feline CKD, and so it merits exploration as a potential therapeutic target. Now we said about cardiovascular disease, we said there are numerous studies and they have been published, they're out there, on the effect of indoxyl sulfate and uremic toxins on the heart, the cardiovascular system. Do we have data in veterinary medicine? Well, actually we do. There's again a recent study. All of these studies are quite recent, but there's this study where they looked at ES levels, indoxyl sulfate levels, in dogs with experimentally induced heart failure. So they paced these dogs, rapid right ventricular pacing, for a few weeks. They developed congestive heart failure. And then this group looked at indoxyl sulfate levels. They looked at serum creatinine levels. But they also treated these dogs. So from 4 weeks on, that's what you can appreciate here. So from 4 weeks on, when congestive heart failure was prevalent, was active, they treated these dogs with an uremic toxin binder. And we will talk about this a little bit later, but we can already start talking about the binding of uremic toxins here because of this study. But what happened is, let's first look at indoxyl sulfate levels. So what you can appreciate here is that when dogs go into heart failure, at least these dogs that have experimentally induced heart failure, ES levels go up. So these two bars are dogs that are not treated and dogs that are treated with an uremic toxin. But before treatment, because treatment is starting at 4 weeks, before treatment you can see these ES levels, indoxyl sulfate levels, going up. So as heart failure develops, indoxyl sulfate levels go up. But then, once they start treating for the uremic toxin, placebo-treated dogs will continue showing increased levels of indoxyl sulfate, while in the other group that are treated with a toxin binder, indoxyl sulfate levels are going down. Same is happening for creatinine levels. When we look at the dogs that are treated with a placebo, or dogs that are treated with a toxin binder, there's a statistical difference between both of them after 2 weeks of treatment. So dogs treated with placebo tend to have higher serum creatinine levels than the ones treated with a toxin binder. So this is proof that indoxyl sulfate is somehow important in the development of heart failure, at least in these dogs where heart failure was induced experimentally. But then when these dogs were followed echocardiographically, and I'm just showing a few of these parameters, there's much more in these papers, but what is interesting is that, of course, as heart failure develops, most of these indices become worse, like left ventricular diameter in diastole, left ventricular diameter in systole. They become worse. The heart becomes bigger, and the contractility of the heart goes down, which typically happens in heart failure. But once these dogs are treated from 4 weeks on, there's a difference. Placebo dogs tend to continue worsening, while dogs that are treated with a toxin binder, they have this tendency to improve. And this is not only for the diameter in diastole, left ventricular diameter, also in systole, also for fractional shortening. So the contractility of the heart, it first goes down because of the development of heart failure, but once we treat these dogs with the uremic toxin binder, we can see that these dogs are slightly improving, while the dogs on placebo are continuing to decrease in fractional shortening or continuing to get worse. They also looked they took tissue samples from the heart, and what they could show here is that dogs that were treated, and this is the molecule that was used, AST 120, when these dogs were treated, they had much less collagen in the heart muscle compared with control dogs. So there was much more apoptosis, much more cardiac remodeling in dogs that were treated with a placebo compared to dogs treated with a uremic toxin binder. So the conclusion from this study was, as we already said, indoxyl sulfate is somehow important in the development of heart failure. It is related to the kidney function in these diseased dogs, but at least as important, adding a uremic toxin binder inhibits or partly reverses the cardiac remodeling or inhibits, prevents cardiac remodeling, attenuates apoptosis, and prevents the progression of heart failure in an experimental model. And this is clear evidence that indoxyl sulfate is also in veterinary medicine, as in human medicine, is related to the function of the heart and has a deleterious effect on that function. Now, what do we know about kidney? We said, okay, this is coming from this paper. There are studies showing that this is happening to the kidney when the indoxyl sulfate levels go up. Is this also true for dogs and cats? And actually, I can already say, yes, there is. And there's data out there showing this for both dogs and cats. This is the first study, published in 2015, where they looked at indoxyl sulfate levels in dogs and cats with and without kidney disease. So these were control dogs, control cats, and these were cats with kidney disease, CKD, in stages 2, 3, and 4, cats as well. Now, and what they did, they just looked at serum indoxyl sulfate levels, and they showed that if a dog or a cat has CKD and already in an early stage, so stage 2 here, you can see serum indoxyl sulfate levels go up compared to control dogs and cats. So early stages of CKD have elevated serum indoxyl sulfate concentrations. And this is something that we already saw from a previous paper where they looked at the fecal microbiome, but this is again shown here. So early stages of CKD, already in these early stages, indoxyl sulfate is going up. Between stage 3 and stage 4, there was no statistical difference, not in dogs nor in cats. But then again, from stage 4 on, there was a statistical difference compared with stage 2 and 3. So basically, we now know from this study that indoxyl sulfate will go up as CKD becomes worse, and thus indoxyl sulfate concentration, the serum indoxyl sulfate concentration is related to the presence of azotemia. Then there was this second study where they went a step further. They took dogs and cats with CKD, 36 dogs to be precise, 58 cats, and they classified them into a group where they saw progressive disease and non-progressive disease. And the definition of progression was a 0.5 milligram per deciliter increase in serum creatinine during the same stage, within 3 months, or a change of iris stage within 3 months, so an increase in iris stage. And they could show, and this is represented here, they could show that if a dog or a cat has progressive disease in stage 2 or stage 3, serum indoxyl sulfate levels will be higher. So the more severe the disease, the higher the serum indoxyl sulfate concentration will be for dogs and for cats in stage 3 and stage 2. So we now know that not only indoxyl sulfate is related to the presence of azotemia, so to the kidney function, but it's also a sign, and actually in this paper they did multiple regression analysis and they showed that indoxyl sulfate is an independent predictor of progression of CKD as well in dogs as in cats. So we're always coming back to this review paper and we're just doing our round. So now we said, okay, we have shown that in cats this is happening too. So the microbiome, the changes in the microbiome is happening in cats. We showed with this paper on experimental heart failure in dogs that there are some deleterious effects of indoxyl sulfate on the heart, and we now have this data showing that indoxyl sulfate is actually related to kidney disease. What about bone? Well, there is this also, again, a very recent paper published in 2019 where the group looked at what is the influence or what is the association of indoxyl sulfate with fibroblast growth factor 23 and kidney disease in cats. What is happening there? Is there any correlation? So what do we know about FGF23? We know that it's involved in the homeostasis of phosphate. So whenever serum phosphate levels go up, FGF23 will be secreted by osteocytes and osteoblasts, and it will try to decrease serum phosphate levels by, for example, deposition of calcium phosphate in the body. Studies have shown that FGF23 as indoxyl sulfate will go up when CKD develops in dogs or in cats, and it is related to the severity of CKD. We also know that it's a sign of progression. So FGF as indoxyl sulfate is related to the severity of kidney disease, but it's also a sign of progression of kidney disease. So what this group did was actually looking, okay, we know that there's a correlation between indoxyl sulfate and FGF23 in human medicine, but is this also true in veterinary medicine? And they looked at cats with different stages of CKD disease. Actually, there were 20 control cats, and then we had 38 cats in stage 2, 23 in stage 3, and 12 in stage 4, and they looked at all of these parameters. The goal was to see which of these parameters is independently associated with FGF23 in these cats. And so what you can see here on the left, these are very busy slides. I took them out of some pictures out of the publication, but let's talk you through. So what happened here is that they looked with simple regression analysis. They looked at each parameter having a correlation with FGF or not. And many of these you will see on the p-values that you can see over here. You will appreciate some of these that are actually linked to FGF. But in the multiple regression analysis, when they corrected for all of the other factors, there was only one variable that was significantly correlated and independently correlated with FGF, and that's indoxyl sulfate. So they are correlated. So the first question in this study was, is there a correlation? Yes, there is. ES is an independent factor associated with FGF concentration. But when they looked a little bit further and they looked at the correlation between FGF and phosphate ES, and FGF and ES, they all were correlated to each other. But when they corrected for ES, it was found that the correlation between FGF and phosphate was lost, meaning the influence on phosphate and the influence on phosphate is probably the influence on phosphate by ES is probably going through the action of FGF23. So these are all ES and FGF is linked to bone metabolism, to calcium and phosphor homeostasis. When they looked a little bit further and they divided these groups in a progression and a non-progression group, and they used the same definition as what has been used before in one of the studies that I showed you earlier. Again, these are the variables that are associated or could be a sign of progression and non-progression. But when you correct for all of the parameters, there's only two variables that remain independently associated with progression of disease, and that's indoxyl sulfate and FGF23. So again, this is a clear evidence that ES and FGF are correlated to each other and correlated not only to the presence of CKD, but also to the progression of CKD, and that ES, and that's what I wanted to show you here, that ES is involved in bone metabolism. So okay, now that we know all of these, and let's go back one slide, we know all of these influences of indoxyl sulfate. It has an effect on multiple organs. It has been shown in human medicine, but we have lots of data showing that there's enough, that there's clear evidence of an effect on different organs in veterinary medicine as well. So now what can we do about it? Then let's take a step back to human medicine. Let's look what happens or what is happening over there. In human medicine, there's a product that is called cremizin, based on AST 120. And AST120 or cremazine is licensed for use in CKD in human patients in some countries. What is it? AST120 is a form of activated charcoal, but it's semi-synthetic. It's synthetic. It has nothing to do with the activated charcoal that we know that we use to bind many things in the gut, but of activated charcoal, it has never been shown that it binds uremic toxins. AST120, it does bind uremic toxins. These are black, porous, very small particles. They're little rounds, like little small cannonballs. They all have a certain diameter of 0.2 to 0.4 millimeters. And they consist of many pores. And it's these pores with a certain specific diameter and a volume. It's in these pores that uremic toxins are bound. And the good thing about AST120 is that they only bind uremic toxins. They don't bind any digestive enzymes. They don't bind nutrients. They don't bind vitamins. And this has all been shown in studies. This is not the case for activated charcoal, as I said. This binds many stuff. And we don't even know if it binds uremic toxins. And the good thing about AST120 as well, are these small particles, this semi-synthetic charcoal, is that it's not metabolized, it's not broken down in the gut, it just is eliminated in the feces, the same form that it goes in. So this is a microscopic picture of dried feces of a cat, where you can see these small balls under the microscope. They're not changed, they just bind these precursors of uremic toxins. Now I told you, okay, this is a product that has been registered in some countries. In Asian countries, it's used for CKD patients. And the indication states for use in delaying the initiation of dialysis and ameliorating the symptoms of uremia in patients with progressive CKD. And since introduction in the market, in the Asian market, multiple studies have been done. Phase 3 studies, also post-marketing studies, have been done in Japan and some other Asian countries. And they consistently show that AST120 or cremazine is able to delay the progression of CKD. It has been shown that it improves clinical symptoms, clinical signs of nausea, anorexia, halitosis in these patients, better than it does, or compared to a placebo group. It has been used in patients with early stage overt diabetic nephropathy, where it has been shown to diminish or slow down the progression of renal dysfunction. It has shown that in non-diabetic CKD patients before dialysis, it has been shown that there's a reduced arterial stiffness, so the effects on the cardiovascular system are diminished when AST120 is added to their treatment protocol. So this is in Asian countries. Now there's a nice study. Actually, there's a few publications on the EPIC trials. These are huge trials that have been done on more than 2,000 patients in North America, Latin America, Europe, trying to show similar results. So what happened is they added AST120 or placebo to standard therapy in patients with moderate to severe CKD, and they looked at can we slow down progression of disease. And slowing down was the primary endpoint in this study was the time between the start of the study and the initiation of dialysis, kidney transplantation, or the time that serum creatinine concentration doubled. As I said, it was a huge study on more than 2,000 patients, 239 sites, different in 13 different countries. And actually, it was divided. There were two trials. If you go into the literature, you will see there's an EPIC 1 and an EPIC 2. The difference is in sites. The protocol is the same. Plus, in the EPIC 2 trial, they added in a quality of life assessment. But apart from this, it's just the sites that were different. The protocols were exactly the same. Now, when we look at the primary endpoint, or the reaching of the primary endpoint in the EPIC-1 and the EPIC-2 trial, you will see that there's no difference. So at first glance, when we first looking at these results, we don't see a difference between people who are treated with AST120 or people that are treated with placebo in this study. So showing there's not really an effect of AST120 in CKD in these patients. But when subgroup analysis was done in EPIC-2 trials, you could see that for some patients there was a beneficial effect. Patients with a higher urine protein on urinary protein or creatinine level, patients that were over 65 years, patients in the United States, and patients with anemia. In these patients, there was a statistical difference between AST120 added to the treatment protocol or not. When looking at the quality of life questionnaire, there was no influence on no treatment effect. But most importantly, in subgroup analysis, there was something. There was a statistical difference between, or there were some beneficial effects in adding in AST120. And the same was seen when we look at the glomerular filtration rate. In EPIC-2 trials, the GFR is better in treated patients, in treated people with AST120 compared to placebo-treated patients. So multivariate regression analysis from these studies, and we all appreciate that this was very, very complex studies with a lot of variables. But what was shown in these studies, first of all, what was shown is that if people had a urine protein or creatinine level higher than 1 and they had hematuria, they were independent risk factors for disease progression. So they had a more rapid progression of disease than patients that did not have it. But what they could show in terms of AST120 added to the treatment protocol is that patients that were having or showing proteinuria and having a urine protein on, hematuria, and having a urinary protein on creatinine level higher than 1, and being treated with an ACE inhibitor or an angiotensin receptor blocker, these patients benefited from the addition of AST120 to their treatment. When patients were negative on hematuria, or when they did not have a high UPC ratio, they did not benefit from the treatment. So there's a subpopulation of, at least this is in these studies, it is shown that there's a subpopulation of people, these people with highly progressive CKD disease, they will benefit from the addition of AST120 to their treatment. And this is very important. So how is this in veterinary medicine? Okay, so now we know we can bind these uremic toxins. AST120 exists in human medicine. What do we know about this in veterinary medicine, the binding of uremic toxins? Now, quite some years ago, there was a poster presented at an international congress where in this study, AST120 was used in an experimental model of CKD in cats, and it was tested if AST120 was, if it was possible to bind or to diminish serum indoxyl sulfate concentrations in cats with induced renal failure. And actually, these were two studies. In one study, there was these were dose-defining studies. So they started with 50 milligrams per kilogram for 2 weeks, measured serum indoxyl sulfate concentrations, then went up in dosage to 100 to 200 milligram per kilogram. And in the other study, they gave nothing, so no AST, then 100 for a month, and then again no AST. And these are the results. So here we can see the serum indoxyl sulfate concentration for study A, study B. And what we can see is that once we add in a small amount of AST, 50 milligram, serum indoxyl sulfate concentrations are going down. When we add in more, concentrations are going down even more. But this is staying stable when we double the dose from 100 to 200. So probably 100 milligram per kilogram is the right dose for AST 120. And when we look at study B, we can actually see this happening again. So adding in 100 milligram per kilogram effectively reduces AST 120 in the blood of these cats. Now, in veterinary medicine, we have a product that is very, very similar to AST 120. It's Renaltec. The product name is Porus 1. The difference is in the binding capacity, which is related to the number of pores and the diameter of the pores in these particles. So these are also semi-synthetic activated charcoal. They are also spherical particles. They are a little bit smaller, 0.1, 0.2 millimeter in diameter. They have numerous pores. They have more pores than AST 120 has. And all of these pores are positively and negatively charged, and they bind these uremic toxins. And also for Renaltec, it has been shown that they bind very specifically. So they don't bind any digestive enzymes, they don't bind vitamins, they don't bind nutrients, they just bind these uremic toxins. When given orally, they just pass through the gut. They bind precursors, but they are not metabolized. They are not broken down. They don't stick to the intestinal wall like you sometimes see with the normal activated charcoal. And this is how it looked like. You have seen this picture before when I showed you AST 120. Actually, it's Renaltec. It's a microscopic picture of a cat feces, dried cat feces, with these small particles in there. So you can appreciate that there's no breakdown. There's nothing. They just come out in the same form as they went in, as a matter of speaking. And something nice to know, when the inner surface is calculated of a daily dose, and a daily dose is 0.5 gram or 500 milligrams per kilogram, when we look at the daily dose, the inner surface, it equals the surface of 3 tennis courts, which is amazing. Now, I told you AST 120 and Renaltec, the difference is in the binding capacity, and this is shown in this lab study. So the red line is the concentration, is the concentration of indoxyl sulfate when Porus 1 is added to the solution, and the blue line is AST 120. And so what is happening in these studies is that they just mix in a certain concentration of indoxyl sulfate with a certain concentration of Porus 1 or AST 120, and they measure how much time it takes before all of the indoxyl sulfate is absorbed out of that solution by the toxin binder. And what you can see here is consistently that after a few hours already, 2 hours, there's much more indoxyl sulfate bound by Porus 1 than it is by AST 120. And these are different concentrations of indoxyl and concentrations of Porus 1 and AST. But you can always see that, especially at the beginning, there's much more binding capacity for Porus 1 than there is for indoxyl sulfate, which gives Porus or Renaltec an advantage. There's also a field study, or at least an in vivo study, that has been done in geriatric cats. 18 cats between 11 and 16 years old have been given or Renaltec, 12 cats, and this is the daily dose, 500 milligram, or placebo. They all went on the same diet, and they received a cat snack. The cat snack is developed to make Porus 1 stick to the dry food, otherwise it would just fall through. And the duration is 8 weeks. And during these 8 weeks, every 2 weeks, a blood sample was taken, and every 4 weeks, urine was collected. And in blood, urea, creatinine, SDMA, indoxyl sulfate, of course, and phosphorus levels were measured. And in the urine, protein, creatinine, and specific gravity was measured. So this is the setup, very straightforward. Every 2 weeks, a blood sample, every 4 weeks, a urine sample. Some cats, 12, received Renaltec, 500 milligrams, and the others received placebo. These are their indoxyl sulfate levels. For each cat, this is the Renaltec treated group. This is the placebo treated group. what you can see in the Renaltec group is that indoxyl sulfate levels consistently go down. And at day 56, they're all lower than at day 0. And if you take their mean concentration, the mean indoxyl sulfate concentration goes down with 60%. Right? There's a statistical difference when you compare the end or 2 months with start of the study. In the placebo group, this is not happening. So what you can see here in 3 cats, indoxyl sulfate levels will remain constant, and in 3 others, indoxyl sulfate will go up. And that's the reason why, if you look at the mean, it's slightly going up, but statistically there was no difference between the start and the end of the study. This study is showing, okay, if you add in Renaltec to geriatric cats, and some of these cats had probably overt preclinical CKD. If you add in indoxyl sulfate to these, if you add in Renaltec to these cats, indoxyl sulfate levels will decrease significantly. So coming to the end of this webinar, we talked about the different treatment modalities in CKD, and we said, okay, but this Uraemic syndrome, we need to look at this because this is interesting. And we looked in veterinary and in human medicine what we have as evidence, and we now know that in this Uraemic syndrome, indoxyl sulfate is probably the most important molecule. And we know that indoxyl sulfate is related to the disease, CKD, in dogs and cats, and is related to progression of disease in CKD, and has numerous effects on very different organs, the heart, bone, and so forth, and the gut. We know from human medicine that there's a product, and we can bind these Uraemic toxins. The product is called crimizin, and we now have in veterinary medicine a product that is called Poris-1, with the active being Renaltec, for which a study has shown that indoxyl sulfate levels in geriatric cats go down if you treat them with a daily dose of 0.5 grams per day. So we've come to the end of this study. I hope you enjoyed it. I hope you learned something, and I'm open to take any questions.
Thank you so much, Jose, for a brilliant presentation. Really good to review, obviously, CKD in cats, but also really nice to focus on the Uraemic syndrome and the toxins. As you said at the beginning, actually, it's something that's quite often overlooked. We get carried away a lot with all the other management side. So it's really nice to include that when we talk about CKD and how we can help manage that side of things as well. So absolutely brilliant. Thank you very much for that. We do have some questions, and I think we have Nikolaus as well on the call.
Yes, I'm here. Good evening, everybody.
Excellent, excellent.
Good evening from my side as well. I hope you can hear me well.
Yes, yeah, we can hear you. Thank you. And Jose, can you still hear us?
Yeah, absolutely.
Oh, yeah, excellent. So we, obviously this is a very virtual meeting, so we're all in different places on the one call, so we'll have to kind of try and work it out. So we had lots of questions actually about indoxyl sulfate, so a lot of people really interested in that side of things, which is really nice to cover, because like I say, it's probably something that when we talk about CKD, we don't really talk about that side of things, do we? We talk very much about SDMA and urea and creatinine and that kind of thing. So I'm just going to try and put the questions in some kind of order, so it kind of makes a little bit more sense, I think. So you gave us lots of really useful information on indoxyl sulfate. So I guess the first question is, how is it measured? Is there a commercial test available? Is it a blood test? Is it feces? Where are we at in terms of being able to measure that?
Yeah, well, so far we can't measure it commercially. The test doesn't exist yet, but I know Klaus and his team from Poris, they are working on it. So maybe I can ask Klaus to comment on the availability of a commercial test, maybe in the near future. Klaus, can you say something about that?
So see, I can even accomplish that. It is now available from LaboClean in Germany at least. I don't know whether in other countries as well. It's very recently launched, so maybe a couple of weeks ago. It is available as an individual test. In our studies, we used a laboratory who did a specific, who set up this specific analytical test for our purpose, calibrated it, and then did the measuring. So at that time, it was not yet available. Now it is, but it's the only source I know for the time being. Okay,
excellent. So if any of our listeners in Germany, they're in luck because they've got obviously LaboClean. And is that a blood sample or feces?
Yeah, it's a blood sample.
It's blood sample. Excellent. Okay, so that's a really good starting point then. So we know. So hopefully that's something that will develop. So a kind of a question following on from that is. If we get to a point where it's more commercially available in other countries, globally, do you think that would be a good measure for early detection of CKD? So a bit maybe like SDMA is at the moment. Do you think that's something that might develop in the future?
Well, yeah, that's a very good point. We don't really know if it can be used as a sole diagnostic measure because it elevates in all kinds of retention of this indoxyl sulfate. So if it will be used as a sole marker for CKD, we don't know. We know that it elevates early in CKD. I've shown these studies from Chang and Chang and their teams already showing in stage 2, iris stage 2, that indoxyl sulfate is going up and is significantly higher than in normal dogs or cats. So it could be a good indicator of early disease, but we need to do more studies to finalize that.
Excellent, brilliant, that's great. Yeah, I think it's just one of these things. I think when people learn about something new, it's like when can we have it? When can we have it? And how can we use it? So it's a really exciting development, isn't it? And certainly one to keep an eye on for the future. So. That's brilliant. So that kind of covers indoxyl sulfate. We've had a lot of people. We've got a lot of people, particularly in Europe, but also other countries. So North Africa, Canada. I saw someone as well. Lots of people saying, "Is it available in my country?" So maybe Niklaus, if you could just go through where Porous 1 is currently available, and if you have any plans for it to kind of go to other countries.
Yes, currently it is available in 6 European countries, so in UK first, in Belgium, Netherlands, and in the German-speaking countries, Germany, Switzerland, and Austria. There we are in the market since about 2 years and a half about. So we have a bit of experience there with Porous 1. And we intend also to go to the United States. Whether that will be possible in the next year, we will see, but we work on that.
Okay, excellent. And any plans for other parts of the world at all, other parts of Europe even, or was it just all?
Yeah, other countries in Europe, of course. So France would be certainly an interesting country with a lot of cats, and other countries as well. At the time being, we look for various partners, but it is not yet decided. So for the time being, for the next couple of months, we will be still limited on these 6 countries, what I mentioned in the beginning.
Okay, no problem. And if it is available in your country, how do practices go about getting it? Do they get it through like a veterinary wholesaler, or do they get it direct from you? How would they?
Yeah, they know we have to do it via a wholesaler. We are a very small company, so we cannot afford our own sales force, for instance. So it was our obligation to go to a distributor. That's what we did for the 5 countries, except of UK, with a company, with a wholesaler, Covetrus. Whereas in UK, we work with XL Vets for the time being,
Excellent.
XL Vets.
Yeah. Because I do know you've got a brilliant website, so I think that's the thing to do, isn't it, is for people to kind of have a look. I'm just going to pop that up now, so we've got your website. I realised I hadn't gone on to the next slide. There we go, porous.1. So people can obviously check out your website for more information and
Absolutely.
For finding out if it's available, etc. So that answers quite a lot of questions, because there's people, I think, Morocco, India, lots of people asking if it's available in their country, Greece, Spain. So hopefully that answers, and if it's not available yet, hopefully it will come not too far in the future.
We work on that.
Yes. Brilliant. So lots of interest there. Having a quick look through, good question here from Zhao. Are there any interactions of Porous 1 with other medications that would typically be used in CKD patients?
Yeah,
so
of course, that's a good question, and we know about anyhow the challenge to do oral medication. So nevertheless, there are a number of medications which are given orally, and we tested it only since it is rather complicated to test this interference. We did it just for the product Semintra from Boehringer. Yep. That is something where we can exclude that there is any interference. So they could be given at the same time. But since for the majority of the products we can't guarantee that there is some impact on the efficacy of the other products which are orally supplied, we recommend in general to give everything which is administered to the cat orally prior to the Porous 1 application, since all of them are absorbed within 1 or 2 hours usually after swallowing. So when Porous 1 would be given with a distance of 1 or 2 hours after all other oral medications, we should be on a safe side. And Porous 1 could start its work, which is entirely for the entire period in the intestine. It remains there to 100%. So then there would be a very small risk that there still these 2 or 3 compounds are meeting in the intestinal tract.
Excellent. Brilliant. So I'm just having a look through lots of feedback, lots of questions. So I'm having a quick look through. So that's obviously using with other medications. What about, because obviously cats with CKD often will have concurrent conditions. So I'm thinking from my own personal experience with a cat with CKD, hypercalcemia and constipation, for example. So does Porous 1 have any impact, or is there any reason that you wouldn't want to use it in things like hypercalcemia, for example?
No, of course we get many of these questions, and as far as we see right now, those cats who are suffering from a number of concurrent diseases, think also about diabetic cats or so, we wouldn't see any problem to give Porous at the same time. The only thing we can imagine, if there is a disease which is really impacting the intestinal tract itself with ulcera or other lesions, let's say, then since Porous 1 is a strong mechanical product, even if it's a very tiny little beads, theoretically there could be a threat by that. Anything else, I would rather say that we didn't hear anything about, let's say, a negative impact during the treatment of this concurrent disease. As you have asked the questions, what about a combination of oral medications? Of course, we have to take care, but for the other symptoms, etc., we don't know about any other impact. So it can be basically given to almost any cats where the intestinal tract itself is not hurt severely. Excellent,
fantastic. Okay. Brilliant. So another question here about, because it's a daily product, that's right, just once a day. Yeah. If you had someone that couldn't give it every day, is it better to give it every 2 or 3 days, or if you can't give it every day, then it's not worth giving it? See what I mean?
Frequently get the question. So for people who are really very cost sensitive or so, I frequently got the question: should I better give it than half a stick? I give it every second day. So if I get these questions and there's really a problem in cost, then I would rather give half a stick on an everyday base. Of course, then you just get less in dole bound, for instance, as to give one example of these precursors of the Uraemic toxins, you will have a reduced effect, but you still will have one. And think about the fact that we have for all cats anyhow one stick with the same content, and we were frequently asked why doing that, because cats are also different body weight and they are different in consumption. That is correct. But nevertheless, the cats do us a favor compared to dogs, that their body weight ranges are relatively limited, and we give a good portion with the 500 milligram. We feel on the safe side. When we developed the product, we got some orientation from a Japanese product, a very similar product. AST 120 was mentioned by José several times, and this is dosed at 400 milligrams, and it is a little bit less potent than ours. So with 500 milligram, we feel a bit on the safe side. But nevertheless, we have also to underline that all our good results we got are usually generated with a daily application of one stick.
Excellent. And it's a permanent treatment as such, isn't it? As in, it's, you know, once the cat's diagnosed and you've prescribed it, it's kind of permanent. You every day. It's not a course of 2 weeks, for example.
Of course, we think so, because unfortunately there is no cure of this disease. So we interfere the moment we see the base of the functionality of the nephrons, and at the moment we interfere. So we may be able to keep the process on hold for quite some time, and that is finally the target, to give a good time to the kidneys, give a good time to the cat for the time which is as long as possible. So for the time being, there is no ratio then to interrupt. If you have a defined diagnosis of CKD and you have compromised kids and a reduced GFR, why should you stop? You would just stop the benefit which you give to the cat.
Mm-hmm. Yeah, fair enough. Excellent. I was just having a quick look through the questions, but I think a lot of the questions are similar, so I think we've actually covered all of them there. Someone's asking how palatable it is if the cat won't take it in food. Can it be syringed? I guess that's another option, but you do have the little plus one.
That's one.
One plus, yeah. To put it in as well, don't you? So.
Yeah, we also frequently get this question, what can I do if it is not? Yeah, our target, of course, is a voluntary uptake, which is really important. And if cat owners are calling us, we never give the advice to give it in a syringe. But there may be people who are sufficiently experienced and do not risk a respiratory problem by doing that. That is the risk we see. Yeah. Of course, porous 1 is not soluble in water. We won't have a solution in a syringe. We just have a suspension, which you have to mix up and put it in. Certainly, there are exceptionally there may be success with that, but by far the better method is give a very tasty snack and then have the cat swallowing up within a few seconds. And that is what usually happens with one of the two tastes we have in the meantime, two tastes. And usually, I would say a big percentage of cats, even the sensitive one, are very keen on this little snack. And with the little snacks, they will take up the porous 1. Porous 1 itself is totally neutral and doesn't bother the cat by his character, the mechanical character. It doesn't have any smell. It doesn't have any taste. So it means whenever a cat would take up a food and a liquid food and a porous 1 is mixed in, it will be more or less guaranteed taken up.
Excellent. Fantastic. Thank you very much for your time, both obviously to José for the presentation and to you both, José and Niklaus, for the Q&A as well. I hope that was really nice just to have you on the line at the end, just to kind of pick up any of those little questions that people may have had throughout the presentation. So I think that's nice. And thank you once again for your time this evening.
Thank you very much for your kind moderation and professional moderation.
Oh, thank you. Fantastic. So just to everyone still listening, see everyone's still with us, so that's absolutely fantastic. Don't forget to take advantage of the materials. So in the resources section, you've got the downloadable materials. There's your CPD certificate, but there's also the fantastic additional information on porous 1, etc., that you can download. So please have a look at that. You'll get an email tomorrow with the link, so you can come back, you can watch the whole webinar again if there was anything you wanted to revisit or you didn't quite catch, or you want to look at a particular slide in more detail. Then you can come back and do that at any time. And again, those materials will remain there as well if you haven't got time tonight, for example, to download them, or you're on a device that doesn't allow you to download. You can come back tomorrow from a laptop, for example, and get everything off of there. So I hope that you have enjoyed the webinar. So ISFM, we actually do a whole load of free webinars. So I hope that you've enjoyed this session. If you are looking for more kind of free CPD, which gives you a nice certificate at the end as well, particularly obviously feline CPD, which is what we're particularly interested here at ISFM, then do pop over to our website, icatcare.org. There's a little section called Education and Events. If you go into there, then you will find a bit that talks about our webinar channel. In the webinar channel, we have over 50 webinars on all things feline medicine, feline behaviour, surgery, all sorts of things that you might find interesting, including some more things on CKD, but this will be the first webinar where we're actually talking about uremic toxins and uremic syndrome, so that will be a nice addition to that. So please do, if you want more webinars from us, then that is there. It's absolutely free. You sign up, free to sign up, and then you can access, I'd say, over 50 webinars at any time, and we'll be adding this tonight's webinar to that selection as well. So if you have time at some point, please do pop over to there. So I think we'll wrap it up for tonight. I want to say, obviously, a massive thank you to everyone for joining us, particularly people from more further afield from the UK, so Canada, India. I think we had someone early on as well. Obviously, all parts of Europe. Appreciate for some of you it's much later than it is for me here in the UK. So thank you very much for joining, and I hope you enjoyed it. And of course, once again, thank you to Jose and Niklaus for this session as well this evening. So thank you very much.
Thank you.
To everyone, and until next time, hopefully see you on another webinar soon, but until next time, good night.
Goodbye.
Goodbye.